So I'll be speaking today on code status, patient choice, or medical decision. And I wanted to start by presenting the case of a patient whose care I participated in July in our hem-onc unit of our hospital. Mary was a 59-year-old woman who was diagnosed with AML in January of this year. She was treated with the standard chemo regimen but didn't respond well, and she was admitted in June to attempt a second-line chemo regimen. On my first day in the unit, during rounds, the attending told Mary that this second-line chemo was not working for her. Her white count was rising through the chemo, which she had never seen before. He had determined that the chemo should be stopped that day and that he was not going to offer her any further chemo. When we left the rounds on the second day, when we left Mary's room, we had a new senior resident, and he said, "We absolutely should not code that woman." He turned to the intern and said, "Make sure she becomes DNAR." So the intern entered her room several times that day with the intent of having this discussion, but couldn't bring herself to do it. So on the third day, she asked the attending to have this discussion. During rounds, the attending went in and recommended to Mary that resuscitation would not be consistent with the goals of her care at this time, but ultimately told Mary that it's her choice. He couldn't tell her what to do. He asked for a decision. Mary cried, but she didn't respond and remained full code. Later that same day, Mary's oxygen requirement was going up significantly, and it was clear that she was declining quickly. At that point, the intern entered the room and told Mary that she was being made DNAR. Mary actually took this relatively well, and by the morning of the next day, Mary died a relatively peaceful death, surrounded by her family, and thankfully not by the code team being coded in her final moments. I think this case illustrates well that there is still a lot of confusion about who should make this decision about code status. Is it the responsibility of the medical team or the right of the patient to make this decision? In the case of Mary, we initially offered her this decision and later the same day made it ourselves. So today I'd like to talk to you about the principles of medical ethics, a few of them as they pertain to the code status decision. I'd like to make the argument for why this should be a medical decision as opposed to what most providers currently seem to behave like, is that it is a patient right or a patient preference to make this decision. I'd like to talk about the history of code status to explain why it is that people think that, and present a new framework for making these decisions. I don't want to talk too much about autonomy and beneficence because I think that it's pretty obvious, it's pretty self-evident how they pertain to CPR and code status decisions. Obviously, beneficence, this can be life-saving. In terms of autonomy, I just wanted to note that autonomy usually means that patients can accept or refuse treatment, but not necessarily demand treatment. In terms of our other four pillars of medical ethics, I would like to talk a bit about non-maleficence and justice, as it's not as obvious how they're connected to this issue. So in terms of non-maleficence, the duty to first do no harm. When CPR succeeds, there is always some harm potentially in doing CPR, but when it is successful, those harms are definitely worth bearing because you could have potentially the restoration of a former quality of life. However, when CPR fails, there can be significant harms that are often discounted by patients and sometimes even providers. Those harms can include dying in an undignified and painful manner, and a post-resuscitative state that is potentially worse than death to the patient. So because the harms can vary so much depending on how likely CPR is to succeed, I wanted to talk a minute about outcomes of CPR. So in terms of patient views of CPR outcomes, they tend to be universally much more rosy than the reality. Patients tend to believe that the survival rate for CPR is something like 70%, and that's based on what they see on television and in the movies. And that presents an opportunity for education because this is the information with which they're making these decisions, and it's not based on reality. In reality, the American Heart Association has a national registry of CPR. In their review of almost 15,000 cardiac arrests, they showed that about 44% of patients survived the initial coding event, but about a third of those haven't survived even 24 hours past that. Again, another third of those don't survive to ever leave the hospital. So you can see that the rate of survival to hospital discharge is something in the 10 to 20% range, and that is very different from what patients believe is the outcome. In terms of functional status, nearly 44% of survivors of in-hospital CPR have a significant decline in functional status, and CPR is now the third leading cause of coma. So given these outcomes, it is important for providers to think harder about offering CPR. And it would be of benefit to understand, since these numbers are just for all comers, it would be benefit to understand for any particular patient what is the likely outcome of CPR for that patient. So I found some studies that looked at pre-arrest predictors of mortality. So based on patient characteristics, there are ways to understand who is more or less likely to survive CPR and ultimately benefit from CPR. So a number of the patient traits are listed there. So for example, patients with cancer have an odds ratio of 4 times of not even surviving CPR compared to the average patient. That makes sense because patients with cancer are in a state of physiological collapse. By the time that they require CPR, it is very unlikely that CPR could undo everything that is already happening in their bodies. Conversely, patients with the cardiac diagnosis actually have a decreased odds ratio because in that case, if they have a cardiac problem, it is more likely that it's temporary and CPR could help reverse that problem. Even more interestingly would be to know when CPR is absolutely futile. So I don't want to go over this in detail, but there are studies where hospital systems look at their patients who receive CPR and try to understand subgroups of patients who never benefit from CPR. For example, MD Anderson found that of cancer patients with anticipated cardiac arrest, 0 out of 171 in one of their series survived. So this type of data would be very useful to us in being able to know when CPR is virtually futile and be able to tell patients with confidence that this is not going to benefit them. I also wanted to talk about the medical principle of justice. Justice demands that physicians must be as fair as possible in offering treatments and allocating scarce medical resources. So CPR, when applied very widely, as it currently is expensive, especially how often it is futile. We know that about 25% of Medicare funding is spent during the last year of life. And in terms of CPR, some of the statistics about the cost of that is for a predicted rate of survival of around 10%, which is kind of what the average is. It costs about $117,000 per life saved. If that rate of survival was only 1%, that would be more like $250,000, and if it was only 0.2%, over $500,000 per life saved. So when we do CPR in situations in which we know that it is nearly futile, it is quite a burden on the system. So why should CPR be a medical decision primarily? In our system, physicians act as gatekeepers, deciding which treatments, medications, and procedures to offer to patients. For example, chemotherapy, surgery, transfusions, amongst many other procedures are decided by physicians who would benefit from these. And coding is ultimately a set of medical procedures as well, and it could be something that physicians decide when it is medically appropriate and for which patients it would be of benefit. But of course, we ideally do this as a medical decision followed by a patient choice. So this is not to say that physicians are unilaterally making these decisions, but the physician first decides what are appropriate options to offer. And so this model that I'm laying out is for all medical decisions and could also be true for CPR. And they do so in discussion in partnership with the patient. The patient can consider those options and the physician recommendations and accept or decline them as per patient autonomy, but again, not demand options. And of course, if they don't like any of the options, they can seek another provider. So then I wanted to go into a second case to illustrate this point a little bit better. In this case, Jonathan is an 18-month-old boy diagnosed with a rare survival with not much a rare cancer with a low survival rate. 3 months into his treatment, he required emergency surgery, began hemorrhaging, and was placed on ECMO, but has not done well on it. A month into that, the physicians want to make Jonathan DNAR, but his parents refuse. They know that he's likely to die, but they believe they must give him every possible chance, even if the odds are 1 in 10,000 or less. The parents tell the team that if they withdraw care against their wishes, that they would blame the team for his death. So I raised this to show that, as much as we hope that as physicians, that our goals would be aligned with patients, and that if we work with patients, we'll come to the same conclusions, sometimes our goals are different. Sometimes patients and their families have the goal of preservation of life or extending every moment of life at all costs, and sometimes irregardless of the quality of life. So if, in that case, CPR is actually a rational choice for patients and their families to make, no matter how likely it is to fail. However, as physicians, if we code everyone who wants that every possible minuscule chance at living, that is not really consistent with the principle of justice. So we don't allow patients to demand chemotherapy or surgery or other treatments that are unlikely to benefit them. So the question is, why do we do this with CPR? So to go into the history of code status, I think that helps explain why CPR has this unique kind of position out of the medical procedures. CPR was invented in the early 1960s. It was invented mainly for the intraoperative rescue of otherwise healthy patients. However, it quickly became an ethical and legal imperative, a presumed universal good. If you could save a life, why would you not do that? And this makes sense for anyone who suffers arrest outside the hospital in the ER. A patient who's unknown, CPR should be performed on them unless they have stated otherwise, because we can't know what their wishes would be. And so we do have an imperative to save them in order that they can make those decisions. The problem is that as part of the natural dying process, cardiac and pulmonary arrest is part of that as well. So by the late 1960s, it was acknowledged that CPR was prolonging suffering in dying patients. By the mid-70s, the AMA put out a statement that CPR is not indicated in certain situations, such as in cases of terminal irreversible illness. And hospitals also started making the first DNR policies to allow doctors to kind of opt out of doing CPR in these types of patients. However, they weren't used very frequently, and they weren't transparent to patients. And so things happened, like there was a case in New York State where in certain hospital systems, doctors attached purple stickers to the physical charts of patients for whom they did not want CPR performed. Unfortunately, sometimes those stickers would fall off and be placed back on the wrong charts. And that became known and then publicized in the media. And that was all part of kind of triggering this backlash when people began to understand that doctors were making these decisions behind the scenes. There was a public backlash against paternalism and a feeling that doctors were playing God, making these decisions without involving patients. And then there were a couple of very famous medical ethical cases, legal cases, that you're probably familiar with, Karen Ann Quinlan and Nancy Cruzan, who are both young women who were in persistent vegetative states, whose parents wanted to turn off life support and were not allowed to by the physicians and the hospitals taking care of them. In both cases, the parents had to sue and went to a state Supreme Court and as well as the U.S. Supreme Court. Who found that the parents should be allowed to turn off this life support and that competent people do have the right to exercise medical treatment. So things started to swing towards this idea of patient rights and patient self-determination, culminating in the Patient Self-Determination Act of 1991 that gave patients the right to determine the kinds of care that they will accept and not accept if they become incompetent. And code status kind of became swept up into this issue as well as a patient right. Again, patients wanted to make their own decisions about these kinds of life or death matters. Many hospital policies began requiring the patient and family's consent for DNAR, and that's still true today at various places, including the VA hospital system. And in New York State, which was, again, where that purple sticker incident happened, they passed a law that required that the family or patient must consent to DNAR, or else, and if that consent is not present, then you must do CPR, even if you believe that it's entirely futile, or else take the matter to court. So this, as you can see, has been kind of a pendulum swinging back and forth between paternalism and patient autonomy. But some of that has not, since the mid-1990s, it has been swinging back to letting physicians be in charge of these decisions, recognizing that overall it's not good for physicians to be doing things that are considered medically futile. The Texas Advanced Directives Act of 1999 was a big part of this. It stated that physicians are not required to provide futile care, and provided a matter of steps that physicians could take to document this to protect themselves when they felt that care was futile and they wanted to decline to provide it. And this was kind of the basis for a lot of hospital futility policies that have come up since then, such as our own, the University of Michigan Health System's futility policy states that when a physician would like to determine that care is futile, they need confirmation by a second physician. They must notify the patient and family that this is a determination that's being made and provide an opportunity for transfer of care to another provider. So this is kind of where things stand right now. However, because I think of the history of how things have already gone, the average provider does seem to think that making the code status decision is something you have to ask the patient and that it's a patient right to do. And of course, there's a lot of medical legal concerns as well. But ultimately at this time, in most medical systems in most states, the physician would be protected in making this decision and determining that CPR might be futile in a patient. So lastly, I just wanted to end by presenting a new framework for making these code status decisions. First, I just want to talk about how things currently go. As I said, currently patient preference prevails. The physician usually kind of starts this discussion when they think that the code status should be DNAR. They approach the patient or family and strongly recommend it, but say that it's the patient's choice. If the patient and family agree, which luckily does happen in the vast majority of circumstances, there is agreement. They have been, in this with the physician. They understand what the medical context is. Then the status is changed in the system and everything is okay. However, in a significant number of cases, there isn't agreement. If the patient or family doesn't agree, then the discussion must continue. Again, if the physician believes that their job is to convince the patient or family, over time, they may eventually be persuaded, or they may never be persuaded. This can be a very time-consuming process for physicians as well in order to get the patient to understand and see the way the physician sees it. This would result ultimately in unnecessary coding if this doesn't change, or ultimately possibly an ethics consult if there really is a lot of disagreement. And then I just wanted to take a moment to talk about this concept of slow codes. Slow codes are half-hearted resuscitation efforts, limited in intensity and duration. The physicians who do them may believe that they're a short symbolic trial of CPR, but the family falsely believes that it may be of benefit. For this reason, most bioethicists and professional medical societies condemn them as deceptive. I think that they used to be done much more openly in the past. It's kind of hard to know how often they're done because it is kind of a gray area about how long someone must code someone and how much effort must be put in, but they definitely still happen. I've definitely heard them talked about on the wards even recently. And I wanted to say that they actually are just a natural response to providers feeling forced to take actions they believe to be futile. If someone asked you to do something that you believed had no point, how much hurry and intensity would you do something with? So it kind of just highlights that something about this system, while it largely works, is not really working in a way that is best for everyone concerned. So this new framework that I want to present was actually published in JAMA in March of this year by Blinderman et al. At Yale, a group out of Yale. And I liked it. This is kind of the way I think about it as well, but they proposed a new framework based on the prognosis of the CPR. So they proposed that you should take different approaches based on how likely you think that CPR is to work for that patient. And I'm going to go over these different approaches in the next slides. So in approach one, when there are uncertain risks and benefits to CPR, for example, if a patient has a chronic illness but not end stage, then the provider could approach the patient and family and give them the option to consider CPR as a plausible option, provide the best information we can about how likely we think it's going to be successful for that patient, the risks that could come from bad outcomes, and at that point, let the patient decide, because we are willing to do this code because we don't really know that it is going to be futile. In approach two, when there's a very low likelihood of benefit and a high chance of harm, for example, in cases of advanced cancer, dementia, cirrhosis, certain subgroups of patients where we think that it's very likely to be futile, the physician could approach the family with a strong presumption against providing CPR, but be open to unique factors that might make an attempt at CPR unusually beneficial for this patient or family, and be willing to acquiesce as long as they think that there's a potential for some medical benefit. However, in cases when the physician believes that CPR would be absolutely futile, for example, when death is imminent or when there is really no chance of the patient surviving to discharge, there is an ethical imperative not to offer CPR in the first place. The physician still needs to explain to the patient and family that CPR is not being offered, and if a disagreement ensues, that's when you would call an ethics consult and document your decision as per futility policies. And I would like to say that this is kind of the case that when I spoke about Mary, that first patient, this is the approach that would have been helpful for her. Mary was in the process of dying as we offered her the option to be made DNAR or to be full code. It didn't really make any sense to offer that option. Coding her would not have had any possible benefit to her, and yet we still made that they made that offer. I think ultimately we then went in and made that decision, and that approach actually worked better for her and created less confusion. So I wanted to say we often offer CPR to patients because we think that we are giving them a choice, respecting their autonomy, involving them in the decision-making, but offering that choice itself can be a harm to patients and families. If you offer a choice that has no benefit and which you really don't wish to perform, you're giving the patient false hope because they think that you're raising it because there is a potential for CPR helping their loved one or helping them. For patients, you're giving them the psychological burden of consenting in a way to their own imminent death. And that's a very hard thing to do. I believe that for Mary, she just simply couldn't bring herself to say, yes, don't do anything when I die very shortly. For families, we're transferring the guilt or religious burden onto the family when we ask them to make that decision instead of us making that decision. And when you give them a choice, a perceived choice often becomes a perceived obligation to take that choice. There's a quote from a paper I saw from a PICU attending in San Diego that I just thought was so poignant I wanted to include it. That person said, what we're essentially saying to the parents of a child where we'd like to make them DNAR is, what would you like us to do if your child stops breathing? How can anyone force the parent to make that choice? Most parents don't want that burden. Many will simply refuse to say the words, let her die, so their child will be subjected to procedures that everyone believes are inappropriate. Few words about that conversation, the code status conversation. Ideally, it should happen in an outpatient setting by a trusted caregiver. How often the discussion often doesn't happen in that setting, sometimes due to patient provider discomfort, an unwillingness to look like you're giving up on the patient prematurely, or time constraints in the outpatient setting. I had a patient who came to us in the HEMONC unit who had seen his oncologist a number of times outpatient. On that day, he had gone to see his oncologist and become hypotensive to the 60s over 40s. At that time, the oncologist wanted to transfer him to either the ER or the floor and started asking him about his code status preferences, which she had never asked him about before. He wasn't mentating at all with that kind of blood pressure. It was an inappropriate time to raise that discussion, which could have been raised earlier. Because of that, patients often end up having this discussion in the hospital with a team of strangers when they're stressed and something is going wrong medically. It's not really the best setting for that. Another thing about early discussion is it gives patients a chance to voice if they feel strongly about wanting DNAR status. We often don't even raise this discussion until the physician thinks that that's appropriate. But unnecessary coding also happens when patients are not asked their preferences, because sometimes it's the physician who's willing to code and it's the patient who doesn't want to be coded. A patient I had also had a father, watched his father die of prostate cancer for the better part of a year in a hospital, and knew well before he was even terminally ill that he would never want to have that happen. So it's good to have these discussions as early as possible, and sometimes they need to be revisited, so the code word is early and often. The last thought I wanted to leave you with was that based on this kind of idea of determining your approach based on CPR prognosis, we do need better tools to be able to prognosticate about which patients would have what kinds of outcomes from CPR. Right now, a lot of that is just kind of clinical judgment and gut feel, but it's very hard to tell someone that you think something's going to be futile if you don't have any real information to back that up. There are actually some tools that would help make this decision more evidence-based. So in terms of prediction of survival after in-hospital CPR, there are a number of tools. Some of the more famous ones are this PAM, MPI, and PAR tools that help you put in a number of characteristics about that particular patient, and that can help you say how likely they are to benefit from CPR. A study of these tools found that they have good specificity, so there are certain cutoffs for each of the tools that if a patient has a number of these characteristics, it's almost certain that CPR would be futile for these patients. So they didn't have great sensitivity combined. Those three tools detected 42% of futile CPR events, but in this case, specificity is more important. It would be good to be able to use these tools and tell patients, you know, we're not offering this because it will not benefit you. The Apache is another tool as well that's been used in this way. So in terms of the take-home points, I just want to stress that coding is a medical procedure and should only be offered to those who could benefit. It's not a patient right to make this decision primarily, but it is an obligation for the physician not to offer it CPR if you don't believe that there's a reasonable chance of a meaningful recovery. And because medical resources are scarce, leaving patients full code when it's medically inappropriate is not okay. And that does happen quite a lot in the hospital because, again, it takes a lot of work and effort if you believe that the patient should be made DNAR to convince them of that. Quite often they're just kind of left full code because that's a lot of work, but it does bring a lot of burden on the system when we do all these inappropriate codes that extend life in a way that's not necessarily meaningful. Taking the burden of choosing DNAR off of patients' families can actually be more sensitive to them. And in keeping with the theme of this conference, the patient-physician relationship, I think that more clarity in this decision-making would actually make these difficult end-of-life discussions go more smoothly for all involved. Right now, the system kind of works, but there's a lot of awkwardness and a lot more kind of psychological pain and suffering related to this than necessary if there was a clear algorithm for making these decisions. Lastly, there is a need for further research to broaden and validate the decision support tools that I spoke of. So I've just put a few of my references up here, but if you, these are my children. If you would like to know any particular reference, please feel free to contact me. And thank you very much for your time and attention.